This conference will now be recorded.
Welcome in, everybody. On this lecture, we're going to be talking about respiratory related emergencies. The five big ones that we're going to be looking at are chronic bronchitis, emphysema, COPD, pneumonia, and asthma. We're also going to be looking at different assessment tools and then also treatments for patients who are experiencing difficulty breathing, shortness of breath, and again, the pathophysiology and disease process behind the five big ones that we're going to be discussing today. So first, we're going to be looking at COPD. Now, this is one of the major breathing emergency disease processes that we're going to come across in our profession within EMS. COPD stands for chronic obstructive pulmonary disease. Now, there are two different kinds of COPD, how they're classified. One is going to be chronic bronchitis. So this is going to be a long-term condition, and there's a continuous buildup of mucus in the lower airway. And then also when we're diving into our medical terminology, chronic being long-term, bronchitis, that is going to be the inflammation of the bronchioles. So for this individual who suffers from chronic bronchitis, they're going to have that mucus buildup, and then also their bronchioles are going to be constricted. So when we're looking at that anatomy and that pathophysiology behind these patients, it's very difficult for them to get oxygen in through the bronchioles to the alveoli where we're creating that gas exchange. And then it's also very difficult for these individuals to then exhale that carbon dioxide, which is that waste material that is a normal process of life. Now, the second type of COPD is going to be classified as emphysema. Now, this is a breakdown of the alveoli, which prohibits gas exchange. So imagine our alveoli basically is a nice formed balloon surface. And so with that nice surface and that nice shape, it allows that oxygen to come into that alveoli, create that gas exchange. That oxygen is then going to get bumped into the red blood cells, in which it can then be perfused to the rest of the body. Well, somebody with emphysema, that elasticity and that shape of that alveoli breaks down. And as a result of that, it's very difficult for that oxygen to actually bind to that alveoli and create that gas exchange. Signs and symptoms, these individuals are always going to have some type of shortness of breath or some type of difficulty breathing. When we actually get called is when that gets beyond their normal difficulty breathing. So signs and symptoms that we could see is severe difficulty breathing or shortness of breath. We could also see signs of cyanosis, which is going to be that blue tinge around the fingernail blades and then also around the lips. They could also complain of chest tightness or chest pain. So one thing, what we want to start looking at as far as their assessment tools is trying to break down whether this is a respiratory related emergency. And as a result of that respiratory related emergency, they're experiencing chest pain, or is it a cardiovascular emergency? And as a result, that chest pain is actually cardiac in nature. Now, obviously, we don't have x-ray vision. We don't have all of the different resources that a hospital might have in order to properly conclude one way or the other, but one assessment trick that we can use is have that individual take a big deep breath, and if they experience significant pain from that big inhalation, oftentimes it's associated with a respiratory related illness or symptom. Other signs and symptoms that we could see, wheezing or any abnormal lung sounds at all, often pinpoint to that. So this should be a no-brainer. Again, when we're assessing our patient, if they're complaining of difficulty breathing, we want to make sure and auscultate over all of those lung sounds. These individuals too, they can also have a productive cough, especially with our chronic bronchitis patients, because we see that excess mucus buildup. So make sure and ask them if they have that productive cough and if they've been coughing up anything, because that can also be a sign of infection as well. So here we can see the difference between that healthy bronchiole, which is nice and wide open, and there's not a bunch of mucus buildup, in comparison to the individual suffering from chronic bronchitis. where they have that bronchiole inflamed, and we can also see that increased mucus production. Then on the bottom, we can see that alveoli on the left, that nice healthy shape, kind of looks like a grape. And again, all of those different areas allows for that oxygen to actually bind into those specific little ports. Now we got somebody who's got emphysema, those membranes break down, and as a result, it's very difficult for that oxygen molecule to actually get bind into the alveoli. Next, we're going to be talking about pneumonia. So pneumonia is a broad term, and basically what it is, it's an infection in the lungs. Some signs and symptoms that we're going to see, these individuals oftentimes have a fever. So anybody who has a bacterial or a viral infection oftentimes is going to have a sign or symptom of a fever. So the body's natural defense mechanism to an invading host like bacteria or virus is going to be increasing the body temperature in order to try and kill that virus or that bacteria. Other signs and symptoms we can see, some chest pain related with a cough, because pneumonia oftentimes is actually a fluid buildup inside the lungs, and it inhibits the alveoli gas exchange too, because that fluid's sitting in the bottom of the lungs. Obvious sign, difficulty breathing, shortness of breath. Severe cases, we could see signs of cyanosis or an altered mental status as well. So there are difference between patient with a healthy airway in comparison to our patient who is experiencing pneumonia. Next, we're going to be talking about asthma. So this is kind of similar in context to somebody who suffers from COPD, only somebody who suffers from COPD has that chronic or continuous difficulty breathing, and it never really goes back to a normal, healthy adult state. That's where asthma is a little bit different, as these individuals will experience that flare-up of that asthmatic attack, but once that asthmatic attack is done, those bronchioles, those lung trees go back to a normal state, and this individual can actually breathe like a normal, healthy adult would. So when we're looking at the definition of asthma, it is a respiratory condition causing airway narrowing and constriction. Excuse me. Signs and symptoms that we're going to see when somebody actually suffers from an asthmatic attack or an asthmatic flare-up: difficulty breathing or shortness of breath. The predominant lung sound that we're going to hear is going to be wheezing. And then they could also experience chest tightness or pressure. Severe cases, we're going to see those signs of cyanosis as well when that pulse oximetry and oxygen saturation begin to drop. There are pathophysiology behind that asthma attack. So again, we're starting off with a normal, healthy airway. That individual starts suffering from an asthmatic attack in which their bronchioles begin to become inflamed. They might see an increase in mucus production. And then oftentimes these individuals do have a prescription to albuterol or Atrovent or both, in which that's going to then open up those bronchioles. And we'll talk about that a little bit later on in this slide. And you guys also got that information in regards to the pharmacology lecture as well. Next, talking about a pneumothorax, a couple of different variations, a simple tension pneumo, and then also a hemothorax. So what it is, it's a leak or a tear in the lung causing air to fill inside that thoracic cavity. And where we see a pneumothorax go into a tension pneumothorax is that so much air and so much pressure gets built up inside that thoracic cavity where it actually collapses that lung. And again, if it continues to go untreated, then it could push basically everything in your thoracic cavity over to one side. So your heart, your trachea, everything that's housed in there is going to be pushed off into one side. And if that doesn't get identified, that individual is going to go into cardiac arrest very quickly. Signs and symptoms that we're going to see could be a sudden onset of chest pain and a sudden onset of shortness of breath. Again, both of these signs usually are a sudden onset. When we're listening to lung sounds, oftentimes one side is going to be clear and you can hear good gas exchange. And then on the lung that's actually affected with the pneumothorax, you're not going to be able to hear anything. So you're going to document that, and your assessment finding is going to be classified as absent lung sounds over whatever lung category it is. So there, our internal picture when we're looking at that normal lung in comparison to somebody who's suffering from a pneumothorax. Now, how somebody can actually get a pneumothorax depends on their body build. So somebody who suffers from a simple pneumothorax, oftentimes our makeup of our patient is going to be a teenager who's tall and skinny. And it's because that pleural lining basically rubs against that skin and it can create that pneumothorax. We also see it in severe trauma patients where they have a significant blow to the chest. And as a result, there's that tear, that leak inside that thoracic cavity that leads into that tension pneumothorax category. I did mention hemothorax too. So hemothorax is actually blood and not air. And so again, significant trauma to the chest, but instead of air leaking into that thoracic cavity, could actually be blood. And there is one other instance where it could be a hemopneumothorax, where we both have blood and air that's building up inside that thoracic cavity, leading into that collapsed lung for that patient. So a respiratory patient assessment. When we arrive on scene, we're going to formulate our general impression. We're going to go through our scene safety and our BSI checks. And then we're going to dive deeper into properly assessing what that patient's chief complaint is or that nature of illness. So we arrive on scene and some red flags should immediately go up if this patient is presenting one or multiple things. If we see that patient in a tripod position, so they're leaning forward, their elbows are on their knees, they're trying to get into a position that would best fulfill them getting the maximum amount of air that they possibly can. Anytime we have a patient complaining of difficulty breathing and they have an altered level of consciousness, that's another red flag, because oftentimes that patient basically doesn't have enough oxygen inside their brain in order for it to function properly. Then if they're only able to speak in 1 and 2 word sentences or unable to speak at all, that means that all of their respiratory drive has to go into getting oxygen into their system, and they can't compensate at all in order to actually communicate with somebody. Other signs, again, that are red flags: minimal chest movement and also pale skin. So some good questions that we can ask this individual. So they're complaining of difficulty breathing. I may ask them if that difficulty breathing gets worse if they lie flat or if they're trying to sleep. And so what this could pinpoint is if they have fluid buildup inside their lungs. Next, get winded easy. So ask them, what were they doing on the onset of symptoms, or what makes it better or worse. So if they get winded easy, or if it is the onset was due to exercise or activity related, then we know that they have a small store of oxygen that's actually built up inside their system. Next, we can ask them if they gained a significant amount of weight recently, and that could be an indication that they do have fluid buildup not only in their lungs, but also in the rest of their body as well, which is going to compromise their pulmonary system. We mentioned this earlier. Do they have a cough, a productive cough, any pain associated with that, and then also hurt to breathe? So what we're going to do as far as emergency medical responders and emergency medical technicians, EMS providers as a whole, always position that patient in the best comfort of care. So whatever position they feel the most comfortable, that they can breathe easiest, that's how we're going to want to treat them, assess them, and eventually transport them. Next, we're going to go ahead and administer oxygen. So especially if any of those warning signs or those red flags go off right away, we immediately want to administer oxygen to them. Now again, we can administer it a couple of different ways. Bag valve mask, if they are not breathing adequately as far as tidal volume and rate. So if they're breathing less than 6 times a minute, if they're breathing over 26 times per minute, and that patient actually allows you to go ahead and ventilate for them, you can choose that route. Non-rebreather mask will give you about 90 to 100% oxygen. And then if they're just complaining of a small shortness of breath, then we can start looking down that nasal cannula treatment. So for those of you in that first responder role, always update your incoming ambulance, give them a heads up of what's going on. Determine the patient's medications. So our patient who has COPD, asthma, oftentimes pneumonia as well, they're going to be prescribed some type of breathing treatment that they're going to take at home, whether that's albuterol or Atrovent or a rescue inhaler. So if it's not in your protocols as far as to administer albuterol or a nebulizer treatment, you might be able to assist that individual with taking that breathing treatment or that rescue inhaler, especially if your ALS level transport is a significant amount of time out. Be aware and always go over your 6 rights before and after you give that medication administration. And then also always reassess that patient as far as what your interventions are doing for that patient. Monitor. Now we mentioned in your EMS textbooks are always going to mention as far as when you reassess the patient, they say that you should reassess them every 5 minutes for a stable patient, reassess that patient every 15 minutes for our non-stable or for our stable patient. So I don't know what you would be doing for 15 minutes, but reassess that patient as readily as you can, basically, especially after any type of intervention. And then you're going to go ahead and transfer that patient. So like I said, listen to lung sounds is a vitally important skill with any EMS provider, and I even recommend doing that for any patient, regardless of whatever their nature of illness or mechanism of injury is. All right, so that concludes our discussion on respiratory related emergencies. Thanks.